Good morning to one and all. I am Dr. Ramakrishna, Senior Resident Ophthalmology. Today we are going to discuss about the topic sclera. The cornea topic, the remaining part will be covered in the next class, that is on Monday and the following classes, because Sir is on leave today. So we'll be dealing with the short topic sclera for today. Okay. So what are the objectives of today's class? So today basically we are going to discuss these four aspects. One is anatomy of the sclera. The other thing is episcleritis versus scleritis. What are those definitions? What is the treatment? How to identify and all those things. And what is a blue sclera? Blue sclera is something which is important. They can be asked for you as PG entrance question also. And similarly staphylomas. So the objectives of today's classes will be anatomy of sclera, episcleritis versus scleritis, blue sclera, and staphylomas. And these are potential 2 marks and 4 marks questions for you in your final exams. Some topics will be labeled red in color. So those red color markings, you better take a note of them. They will be the questions for you in your final exams. So coming to sclera. So all of you might have been known by this time. There are 3 coats of the eyeball. The eyeball has got 3 coats. The outermost covering or the outermost coat is called a sclera. The middle coat is called a choroid. And the innermost layer is called the retina. So there are 3 layers of the eyeball, or 3 coats, or 3 tunics, T-U-N-I-C, 3 tunics of the eyeball. So the outermost coat is called the sclera, the middle one is called the choroid, and the innermost one is called the retina. These are the 3 coats of the eyeball, which you can see in the diagram. So the outermost white one is the sclera, the brown one is the choroid, and the inner yellow one is the retina. These are the 3 coats. So today our class is about the sclera, that is the white structure of the eyeball. So the outermost coat is made up of sclera. So the posterior 5/6 of the eyeball is covered by sclera. The blue arrow which is shown, the posterior 5/6 of the eyeball is covered by sclera, and the anterior 1/6 of the eyeball is covered by cornea, which is marked in red color. So the outermost coat is called a sclera. So the posterior 5/6 of the eyeball is covered by the sclera, and the anterior 1/6, the scleral fibers become transparent, and that layer is called the cornea. So the cornea, already the class is being taken. So we are going to deal about the posterior 5/6 or the sclera today. So coming to applied anatomy of the sclera. So the outermost coat or the outermost covering or the outermost tunic of the eyeball is called the sclera. It is an opaque layer. It forms a posterior 5/6 of the eyeball. So here in this diagram, we can see the posterior 5/6, that is the blue color one is the sclera, and the anterior 1/6, which is marked in red color, which is transparent, that is called the cornea. So the cornea is clear and the sclera is opaque. Next, there is a Tenon's capsule, which covers the outer surface of the sclera. So the sclera has one more layer on its outer surface, that is called the Tenon's capsule. And similarly, anteriorly, the Tenon's, along with Tenon's capsule, there is also bulbar conjunctiva, which is present. Already you all might have been gone through the conjunctiva classes previously taken by Sahiti madam. So the outermost covering is called the sclera. It is an opaque layer. It forms a posterior 5/6 of the eyeball, and the Tenon's capsule covers it on the outer side. And anteriorly, along with the Tenon's capsule, it is also overlapped by conjunctiva. And there is a potential space between the Tenon's capsule and the sclera, which is known as subtenon space. So subtenon space is a potential space between the sclera and the Tenon's capsule, into which we can inject some drugs like local anesthetics or any steroids or any medications. So this is the applied anatomy. So this black one, which you are seeing here, so this black one is the Tenon's capsule, and this wavy line or this striated line is the sclera. So the gap between the two is called the subtenon space. So the black one is known as the Tenon's capsule, and the striated line is the sclera, and the space between both of these is known as the subtenon space, into which we can give any injections. So coming to the other thing, there is also one more space called the suprachoroidal space, which is present between the sclera and the choroid. So there is a Tenon's capsule, followed by subtenon space, followed by sclera, and underneath the sclera there is the choroid, and in between the sclera and choroid there is a suprachoroidal space in which some negative pressure exists, just like your pleural space. How negative pressure exists in your pleural space, similarly there is some negative space between the sclera and the choroid, and that space is called the suprachoroidal space. And there is a furrow near the limbus of the sclera, that is called canal of Schlemm, which we'll be seeing in the diagram. So you can see this one is the sclera, white one, this brown one is the choroid. In between there is a potential space, this yellow one. This is one drug which we have injected into this suprachoroidal space which is present between the sclera and the choroid. So that is a suprachoroidal space into which we inject some drugs. There is a negative pressure present in that suprachoroidal space, that is the yellow space. Similarly, there is a furrow. So this is the sclera and this is the cornea. So this limbus is the junction of the sclera and the cornea. So at this limbus, in the sclera, there is a small depression or a furrow. And that furrow is called a Schlemm's canal. So the anatomy of the Schlemm's canal will be dealt in detail in your glaucoma classes. Okay, so this is the sclera and this is the cornea. The junction of sclera and cornea is called the limbus. And near to the limbus in sclera, there is a depression or a furrow, which is known as a Schlemm's canal, through which aqueous humor drains outside. So what are the measurements of sclera? This is an important question they will be asking you in Viva examinations. So the sclera is usually thin in children compared to adults, and it is thin in females compared to males. And it is thickest posteriorly. The thickness is around 1 millimeter, and it thins out as it comes anteriorly. So the thinnest part of sclera is at the insertion of the extraocular muscle. So this could be a potential PG entrance bit for your examination. So the sclera is thick posteriorly, that is 1 millimeter, and it thins out as it comes anteriorly. And it is thinnest at the insertion of the extraocular muscles, where it is around 0.3 millimeter in thickness. And then there is a term called sclera icterus. All of you might have known about jaundice. The yellowish discoloration of the skin and mucous membrane is called as jaundice. And jaundice is a common English term, and the medical term we call it icterus. So usually we say sclera icterus, but that is a misnomer. Usually during jaundice, the blood levels of bilirubin go up. So when the blood levels of bilirubin are almost 3 milligrams per deciliter, then the blood vessels, blood vessels get stained yellow in color, and thereby gives a yellowish discoloration. So the conjunctiva is a transparent structure which has got many blood vessels. So when the bilirubin levels in the blood are raised, it gives a yellowish tinge to the plasma. So that is reflected in the blood vessels of the conjunctiva. Hence, sclera icterus is actually a misnomer. The yellowish discoloration of the eyes in cases of jaundice is because of change in color of the conjunctiva, but not the sclera. So usually we use the term sclera icterus, that is a misnomer. It is usually the change in the color of conjunctiva which reflects out as yellowish discoloration of the eye. So the measurement is 3 milligram per deciliter of bilirubin. So that is again a question for PG bit. So remember this 0.3 millimeter and 3 milligrams per deciliter. That's how you can remember this. So this is the thickness of sclera. It is thick posteriorly 1 millimeter, and it thins out anteriorly. At the insertion of extraocular muscles around here, it is 0.3 mm, and at the sclerocorneal junction, it is 0.83 millimeters. So what is lamina cribrosa? So the eyeball is attached to the optic nerve. So where the optic nerve passes through the sclera, that part is sieve-like structure. So that is known as lamina cribrosa. So lamina cribrosa is nothing but where the optic nerve attaches to the eyeball. There the sclera is having a little sieve-like structure. It is fenestrated. So that is known as lamina cribrosa. And this is the electron microscopic structure of the lamina cribrosa. So here you can see many pores or fenestrations in the lamina cribrosa, through which the fibers of the optic nerve pass outside and travel into the optic nerve. Next, what are the various apertures in sclera? So there are 3 sets of apertures in sclera. One is the posterior, one is the middle, and the other is the anterior. So what are these apertures? So here in this diagram you can see this one. This is the optic nerve, lamina cribrosa. Around this optic nerve, there are many blood vessels and nerves. So when these blood vessels and nerves have to pass through the sclera, there should be some hole or some perforation in the sclera so that the nerves and blood vessels can enter through it. So there are almost some 15 to 20 or even more than that number of apertures are present around the optic nerve, and these consists of short posterior ciliary arteries and short posterior ciliary veins, and also the nerves, that is the short posterior ciliary nerves. So these are present in the posterior apertures. Similarly, when we go a little forward, near the equator of the eyeball, there are 4 more apertures. Through those apertures, the vortex veins. There are 4 main veins called the vortex veins or vena vorticosa, which drain the eyeball. So these veins pass out through this part, that is the middle apertures. Similarly, as we go anteriorly near the limbus, it is not shown in the diagram, we have anterior apertures through which the anterior ciliary vessels and the long ciliary nerves pass. So there are 3 sets of apertures: posterior, middle, and anterior. Posteriorly, long and short ciliary nerves and vessels; middle, vena vorticosa; and anteriorly, anterior ciliary vessels and long ciliary nerves. So these are the structures passing through the sclera, through the apertures. So coming to histology of sclera. So usually the sclera consists of 3 parts. One is the episclera, So the first one is the episclera, which is thin. It is vascular. It has got blood vessels. It has connective tissue, fibroblasts, macrophages, and lymphocytes. And inflammation of this episclera is called episcleritis. The other two layers being sclera proper. This is a vascular layer and it consists of collagen fibers. And usually the type of collagen present in this sclera proper is type 1 collagen. This is again a PG bit for you. And similarly, there is a lamina fusca. This is the third layer, which is brownish in color and a pigmented structure, which blends with the suprachoroidal lamina. I'll be showing it again in your diagram. So this is the microscopic structure of the sclera. So microscopically, it consists of 3 layers. One is the episclera, which is vascular. It has blood vessels. It has also got the connective tissue. It has got lymphocytes, macrophages, and fibroblasts. The next layer is the sclera proper. This has got no blood vessels. It is totally avascular. It consists of only collagen bundles. The collagen bundles are predominantly of type 1 collagen here. Totally, there are 5 types of collagen in the body, and type 1 is present in the sclera proper. And the third layer is the lamina fusca. Here, some pigmentation is present. Just like your melanin pigment in your skin, there is some pigmentation of this lamina fusca, which blends with the choroid. Coming to nerve supply, it is supplied by trigeminal nerve, and the branch of the trigeminal nerve which supplies the eyeball is the long ciliary nerve, which supplies the sclera. And blood supply, it is via ophthalmic artery, the anterior ciliary arteries and posterior ciliary arteries. The posterior ciliary arteries are again gives branches to 2 types. One is long ciliary artery, the other is the posterior ciliary arteries. So this is in brief about the nerve supply and blood supply. This is for completion's sake. Always remember ophthalmic artery, if you remember, that is enough. And nerve supply, trigeminal nerve, ophthalmic division, long ciliary nerve. So these are the arteries. These are the long posterior ciliary arteries. These are the short posterior ciliary arteries. These are the anterior ciliary arteries. And these are the corresponding veins. So here we have completed the first objective, that is the anatomy of the sclera. So the next topic we are going to deal is with the diseases of the sclera. So anywhere in pathology you might all read about inflammations. So anything if it is accompanied by the term or postfix itis, itis, that means it is an inflammation. So a conjunctivitis is inflammation of conjunctiva. Keratitis is inflammation of cornea. Similarly for sclera, it is scleritis. So in histology of sclera, I have told you there are 3 layers of sclera. One is the episclera, the other is the sclera proper, and the other is the lamina fusca. So if that episcleral layer is only involved and only that episclera is inflamed, it is called as episcleritis. So the clinical picture will be something like this, which is shown in the clinical photograph here. And similarly, if the sclera proper, that is the dense avascular layer which consists of type 1 collagen, if that is involved or inflamed, it is called as scleritis. And scleritis, something looks like which is shown in this clinical photograph. And details about episcleritis and scleritis will be seen in the succeeding slides. So basically, there are inflammations of sclera. One is episcleritis, the other is scleritis. Episcleritis is inflammation of episcleral tissue, which I have shown in that histology slide. And scleritis is inflammation of the sclera proper. So coming to the first topic, episcleritis. This episcleritis will be given as a 4 marks or a 2 marks question for you. So always be prepared for this. And the differences between episcleritis and scleritis always ask you in your practical exam. So you have to completely by heart episcleritis and scleritis. So what is this episcleritis? Definition is, it is a benign recurrent inflammation of episclera and the overlying Tenon's capsule. So I have told you the sclera is covered by Tenon's capsule. Between the sclera and Tenon's capsule, there is a subtenon space into which we can inject drugs. So the Tenon's capsule and the episclera, if both these are together inflamed, that is called as episcleritis. It is usually benign. That means it doesn't cause any severe symptoms. And it is a recurrent type. It usually recurs commonly. So episcleritis definition, when they ask you in exam for 2 marks, you have to say it is a benign recurrent inflammation of episclera and its overlying Tenon's capsule. So it is more common in young adults and it is more common in women compared to males. Coming to etiology, what are the various causes? So in any medical terminology, the first cause you can write it as idiopathic. For any disease, you can, if you write idiopathic as the cause, you are 100 times correct. Almost 95% you will be correct, because most of the things in medical field, we don't know the exact etiology and it is still under research. So anywhere, first if you don't know anything in exam, write idiopathic. So you'll be getting some marks for that. So etiology of episcleritis, first one is always idiopathic. Next, in case of some systemic diseases, like some connective tissue disorders like systemic lupus erythematosus, SLE, or vaginal granulomatosis, polyarteritis nodosa, or gout, which is hyperuric, more amount of uric acid accumulated in the blood, or rosacea or psoriasis. In all these autoimmune diseases, the episclera is more prone to be inflamed. Similarly, in hypersensitivity reactions, like in tuberculosis or to streptococcal toxins. In some people might be harboring streptococcus bacteria in their nose. they'll be carriers for that. So if hypersensitivity reaction develops in these people due to some altered antigenic response, so then also you can develop this type of episcleritis. Similarly, there will be some infectious causes like herpes zoster virus, syphilis, Lyme disease, or tuberculosis. In these also you can get episcleritis. So coming to pathogenesis. So what is actually happening in this inflammation? So in inflammation, whatever happens, rubor, tumor, calor, dolor. They are the 4 signs of inflammation. Rubor is redness, tumor is swelling or edema, calor is rise of temperature, and dolor is presence of pain. So why all these things happen? Because of entry of inflammatory cells. So what are the inflammatory cells? The lymphocytes and polymorphonuclear neutrophils. That is your neutrophils. So whenever there is an inflammation, there is chemotaxis and influx of lymphocytes as well as neutrophils, which come and occupy those tissues. So when there is infiltration of lymphocytes in the episclera, the pathogenesis starts. So due to that infiltration of lymphocytes, it releases some chemotactic factors like interleukins, tumor necrosis factor, etc., and it leads to edema because of leakage from the blood vessels of the episclera. And similarly, there is congestion of the tenons and the conjunctiva. There is redness because of vasodilatation. So when there is a inflammation, there is influx of lymphocytes and neutrophils. They release some chemotactic factors like interleukins, tumor necrosis factor, etc., which cause vasodilatation. But due to that vasodilatation, there is congestion, or due to vasodilatation, the conjunctiva appears red, and the episclera also appears red. And there is, due to vasodilatation, there is leakage of plasma from the blood vessels, and it leads to edema. So this is the pathogenesis, which is same for inflammation anywhere in the body. So what are the clinical features? So symptoms, usually it may be asymptomatic, but mostly it presents as redness. So usually there is redness and grittiness, that is foreign body sensation. Just like if you have any foreign body or some soil, suppose you are going on a bike and some soil or dust falls into your eyes, how you feel, that feeling is called grittiness. So episcleritis patient complains of redness of eyes, foreign body sensation of grittiness, burning sensation, mild photophobia and lacrimation. Photophobia is intolerance to light, and lacrimation is the watering of the eye. These are the symptoms. And what are the signs? So symptom is what the patient tells to us, and signs is what the doctor elicits. So signs, based on our appearance, we can categorize this episcleritis into simple type and nodular type. So simple type is again, simple episcleritis is again further classified into localized or diffuse type. The redness can be localized to one particular quadrant of episclera, or it can be diffused all the eyeball. Similarly, the episcleral vessels, the blood vessels undergo vasodilatation, and they become engorged because of inflammation. So they appear large. The blood vessels appear large and they run in a radial pattern. This is the simple episcleritis. So in simple episcleritis, the redness is usually localized, confined to one particular quadrant, or diffuse over the entire eye. And similarly, the blood vessels are engorged, which are large and radial. The blood vessels run in a radial pattern. So the other type of episcleritis, nodular type. In this nodular type, there is a pink or purple flat nodule, and there is a surrounding congestion. Injection is nothing but redness of the conjunctiva. So usually in conjunctiva, we use the term congestion or injection simultaneously. Both mean the same. Injection is also redness, congestion is also redness. So usually the nodule is situated 2 to 3 millimeters away from the limbus. The nodules are firm, tender that is painful, and those nodules can be moved separately. Again, we'll be discussing this in the diagrams. So this is an episcleritis. So in episcleritis, it can be localized. That is, in one particular quadrant, there may be redness, or the entire sclera can be involved, and the blood vessels become engorged because of vasodilatation. So you can see here there is no inflammation at this, near the limbus. The blood vessels are thin. But here, due to inflammation, there is vasodilatation. So they appear as redness or congestion or injection, and they run in a radial pattern. You can see from the limbus, the vessels are radiating. That is how it is seen in case of simple type of episcleritis. And it can be localized to one particular quadrant, as in the case here, or it can be diffuse, occupying the entire eyeball. Similarly, this is a localized one. The first picture is a localized one, and the second picture is a diffuse one. In diffuse one, you can see the entire eyeball is involved. Similarly, this is a nodular type. In nodular type, what we discussed that there will be a nodule, a purplish to pink color nodule, which is located 2 to 3 millimeters away from the limbus. Limbus is this one, the junction of the clear cornea and this opaque sclera. The junction of sclera and cornea is called limbus, and 2 to 3 millimeters away from the limbus, we have this pink or purplish elevated nodule, which is red in color, and there is surrounding injection or surrounding congestion. Around this nodule, there is some amount of redness. That is called congestion or injection. This nodule is very firm and it is tender. Tenderness is painful to touch, and it is immobile. It is freely mobile over the sclera. So what is the clinical course? So it is usually benign. I told you it is benign and recurrent in the definition itself. So usually it heals spontaneously between 10 days to 3 weeks. Even if you give some drugs or not, also it will resolve. If you give the drugs, the resolution will be at a faster rate. If you don't give drugs, it will take more time. And similarly, there is a term called episcleritis periodica fugax given in your textbook. This is nothing but a diffuse type of episcleritis. Diffuse type means entire eyeball is involved. This is transient. That is only for a little amount of time the inflammation stays, and it doesn't last for 10 days. Just for a few days it lasts and it goes away, and it recurs frequently. Frequently it recurs. That is called episcleritis periodica fugax. It is nothing but episcleritis, but of shorter duration, diffuse type, and which frequently recurs. That is called episcleritis periodica fugax. So what are the differential diagnoses? So you can see that episcleritis diffuse type, it is similar to conjunctivitis. And similarly, the nodular episcleritis, it could mimic a scleritis or a foreign body or an inflamed pingacula. So see, this is a case of conjunctivitis, and this is a case of diffuse episcleritis. So both are looking same. So if the discharge, burning sensation and all these are present, we can say tell it as it is to be conjunctivitis. If those swelling, discharge and nothing is present, then we can say it is an episcleritis. So what is the treatment? Usually we give topical NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs, which you might have read in your pharmacology classes in your second year. That is aceclofenac, diclofenac and all these things. And similarly, ketorolac is one such NSAID, 0.3% we can give topically. And similarly, if to that NSAIDs, if it is not reducing, we give some steroids. Steroids have an anti-inflammatory action, so we give some low-potent steroids, which consists of fluoromethanol or notiprednol. And similarly, topical artificial tears to relieve that foreign body sensation of grittiness. And similarly, we can give cold compresses on the closed eyelids for soothing effect and to relieve some pain. And if the pain is more severe, we can use systemic NSAIDs like aceclofenac or ibuprofen or indomethacin, etc. So this episcleritis can be a short case in your final exam practical. So learn thoroughly about episcleritis. It will also be definitely asked as a viva question. So that was about episcleritis. Next, coming to the next topic, that is scleritis. So episcleritis was the inflammation of episclera. So as per the histology, we have got three layers. One is episcleral layer, the other is the sclera proper, and the other is the lamina fusca. So the inflammation of sclera proper, which is an avascular layer which consists of collagen fibers, type 1 collagen, that is called as sclera, which is opaque in structure. So the inflammation of the sclera proper is known as scleritis. And this is a serious disease. It is not a benign disease like that of the episcleritis. This is a serious disease, and it can also lead to loss of vision if left untreated. And similarly, it is more common in elder patients. When episcleritis was more common in young adults, but this is more common in elderly patients, that is 40 to 70 years. And like episcleritis, this is also more common in females. So inflammation of the sclera proper, it is a serious disease which can cause loss of vision. It is seen in elderly patients and in females. So what is the etiology? So 50% of the scleritis cases have some associated systemic diseases. So what are the systemic diseases? Like connective tissue disorders, which I have discussed with you in the episcleritis cases. So 50% of cases, there will be some systemic disease. Other 50%, the cause is unknown, it is idiopathic. So what are those systemic diseases? It could be autoimmune diseases like rheumatoid arthritis, systemic lupus erythematosus, vaginous granulomatosis, polyarthritis nodosa, or ankylosing spondylitis. All this will be discussed to you in your general medicine classes later on. Here, just to remember the names. And similarly, in metabolic diseases like gout and thyrotoxicosis also, you can see the scleritis. Similarly, infectious conditions like herpes zoster ophthalmicus and chronic staphylococcus and streptococcus infections. Similarly, granulomatosis diseases like tuberculosis, leprosy, and sarcoidosis. And similarly, surgically induced scleritis. After cataract surgery or after any glaucoma surgery, 6 months, within 6 months of the operation, sometimes you can get scleritis. The cause of it is unknown. It is called as surgically induced scleritis. 6 months, within 6 months of the operation. Similarly, miscellaneous like irradiation. Someone, suppose they have some ocular tumor or some skin tumor. Suppose there is some squamous cell carcinoma or basal cell carcinoma of the eyelids. They underwent some brachytherapy or external beam radiotherapy. So that radiation itself may cause the damage to them. Or they might have some head and neck cancer for which they underwent radiotherapy. So that radiation, the eye got exposed to that radiation and they might have got the scleritis. Similarly, chemical burns and BKH is Vogt-Koinage-Harada syndrome. Vogt-Koinage-Harada syndrome. That will be discussed in your medicine classes. So what is pathology? It is a granulomatous disorder. So all of you might have read about tuberculosis, the granuloma in your tuberculosis, which is a 4-mark question in your pathology. That is a fibroid necrosis surrounded by collagen destruction and infiltration of cells and epithelial giant cells and all these things. So same, the pathology of granulomatous disorders, which you learned for your tuberculosis, same thing applies here. The granuloma formation takes place in the sclera. So classification of scleritis is next one more important question for you. So they will ask to classify scleritis. So scleritis is basically classified into infectious type and non-infectious type based on the etiology. And this non-infectious type is again further classified into anterior scleritis or posterior scleritis based on anatomical location. Whether the posterior half, Posterior is behind the equator. If behind the equator it is involved, it is called posterior. If in front of the equator of the eyeball, equator, the landmark is the venae vorticosa, the 4 vortex veins which I told you, where the pierce the sclera, that is corresponds roughly to the equator. So anything in front of the equator of the eyeball is anterior, anything behind the equator of the eyeball is posterior. So scleritis based on etiology, non-infectious or infectious, and non-infectious are further divided into posterior behind the equator, and anterior is in front of the equator. Anterior is further divided into non-necrotizing and necrotizing based on the pathogenesis. And this atheroscleritis, in detail if we see, it is divided into non-necrotizing type and necrotizing type. This non-necrotizing type is again divided into diffuse and nodular, and this necrotizing is divided into with inflammation, without inflammation. This without inflammation is known as scleromalacia perforans. This is a little confusing classification. You have to read it thrice or 4 times or 5 times in order to memorize it. So try to memorize this classification later on. Now we'll be discussing about this individual types in detail of atheroscleritis as well as posterior scleritis. So the clinical features are same for any type of scleritis. Usually the symptoms are pain. There is a deep boring pain. The patient usually wakes up early in the morning, around 3 o'clock or 4 o'clock or 5 o'clock in the morning. The patient wakes up because of deep boring pain, and the pain radiates to the jaw as well as the temple. Temple is nothing but your temporal part. Okay, temporal part is called a temple, and there is also some redness, localized or diffuse, and there is some photophobia and lacrimation, and decreased vision is present in some cases. These are the symptoms. So main thing here is deep boring pain, which wakes up the patient early in the morning. That one you have to remember, and the pain radiates to the jaw and the temple. Temple is the part about the zygomatic process, lateral part of the skull. So coming to signs. So symptoms are same for any type of scleritis. Coming to the signs. So atheroscleritis differentiated into, if we see the classification, non-necrotizing and necrotizing. So this non-necrotizing and necrotizing we are going to discuss now. So first we are going to non-necrotizing type of atheroscleritis. In non-necrotizing there is diffuse and nodular. So diffuse is the most common type, whereas a nodular is the less common type. In diffuse type there is a salmon pink or purple color discoloration of the sclera is seen. And in nodular type, 1 or 2 hard purple nodules are seen, which are seen just like the nodules of the episcleritis. But the difference is in episcleritis, the nodules are movable, but in scleritis, the nodules are immovable. Because episclera is slightly mobile, but the sclera is not at all mobile. The nodules are fixed to the sclera. And as it is diffuse type, usually 1 or more quadrant. Usually more than 1 quadrant is involved with redness. And usually raised area is seen in the involved area of redness. And here in nodular type, there are nodules located near the limbus. And there is an entity called as annular scleritis, in which the nodules are arranged in a ring pattern around the limbus. So limbus is nothing but your sclerocorneal junction. So coming to the signs, non-necrotizing atheroscleritis, it is of 2 types, diffuse and nodular type. Diffuse type is the most common. There is diffuse redness in 1 or more quadrants, which is salmon pink or purple in color, and it has a raised area. And in nodular type, it is less common. There are 1 or 2 hard purple nodules, which are immovable, and they're located near the limbus. There is a special entity called annular scleritis, in which the nodules are arranged in a ring pattern around the limbus. Okay, so this is a type of diffuse type of scleritis. This one is a nodular type. Here you can see a nodule is present in the 6 o'clock position. So how to identify this nodule is, see the blood vessels here, they're running flat. But here you see the blood vessels are getting elevated and they're coming onto this nodule. So this is a nodule. You can see, if you observe clearly, you can see an elevated lesion here, which is a nodule located 2 to 3 millimeter away from the limbus. And how to see that elevation is, this blood vessel is curving around that or getting raised and traveling over the nodule. So this one is a type of nodular scleritis, and this one is type of a simple or non-necrotizing or a diffuse type of scleritis. The first picture is a diffuse scleritis and the second one is a nodular scleritis. So that was about non-necrotizing type. Coming to necrotizing type. In necrotizing is again divided into with inflammation and without inflammation. So with inflammation, it is an acute and severe disease. There is intense local inflammation, that is redness, pain, and all these are very severe compared to that non-necrotizing type and without inflammation type. And there is vasculitis. The blood vessels get obliterated and there is some infarction. And the sclera here, after some time, it gets necrosed. Because the term is necrosis, the sclera becomes necrosed, and it just like your gangrene type in your limbs, it gets necrosed and there is thinned out and sclera becomes transparent. So when the sclera becomes transparent, the underlying uveal tissue shines through that sclera, which is thinned out. And sometimes, usually it is associated with anterior uveitis. That is, the scleral inflammation also spreads through the uveal tissue. That is, there is also anterior uveitis along with the scleral inflammation. Similarly, without inflammation part of necrotizing atheroscleritis is also known as scleromalacia perforans. This can be asked as a 2 marks question. So what is scleromalacia perforans? It is a necrotizing type of atheroscleritis which is present without any inflammation. It is usually seen in elderly females, with rheumatoid arthritis. It is most common in case of females who are suffering from rheumatoid arthritis. Usually there is a yellow patch of melting sclera, that is thinned out sclera. The arterial supply gets obliterated and the sclera becomes dead white because the blood supply to the sclera, the episteral blood vessels get blocked, so there is no diffusion into the sclera. So the sclera becomes dead white in color, and there is a large punched out thin sclera is left behind in the uveal tissue signs, but spontaneous perforation of the globe is very rare. So this one you have to read it twice or thrice, it is little confusing. So this is a case of a necrotizing scleritis with inflammation. You can see that it is all redness. So is the signs of inflammation are rubor, tumor, calor, dolor. So rubor is redness. So that redness is present. So this is a necrotizing type. You can see there is sclera is thinned out here compared to the surrounding structures. So this is where necrotizing type without inflammation. You see it is all white in color. There is no inflammation. Redness is very less. And you can see the sclera is thinned out and the uveal tissue shines through it. And this is the sclera malacia perforans. That is without inflammation. Here you see it is not that much of red. Here this part is all white. There is some amount of redness in the periphery, but not at the center. And this black tissue color is this black or brown color all is due to the shining uveal tissue which is present underneath the sclera. The sclera is thinned out here. So that was about anterior scleritis. It is a little confusing. You have to read it twice or thrice to understand it clearly. Next one is posterior scleritis. Inflammation of sclera behind the equator. That is behind the vortex veins is known as posterior scleritis. It is frequently misdiagnosed because the symptoms are little different and we think it to be some other pathology. And it can be usually associated with exudative retinal detachment, macular edema, proptosis, and there is also restriction of ocular movements. So here you see this is a posterior scleritis. In posterior scleritis, you see this is roughly the equator of the eyeball. The inflammation is more behind the equator. In front of the equator, there is little inflammation, but not that much. Most of the inflammation is located behind the equator. And behind the equator, as the sclera is involved, and in front of the sclera, there is choroid and retina. So you will be having the inflammation spreading to the retina also. So when it spreads to the retina, there will be optic disc edema. There could be retinal detachment. There could be macular edema. That is the edema of the macular part of the retina. And there could be proptosis, forward protrusion of the eyeball, because inflammation of fat which is present behind the sclera in the orbit. And there will be restriction of extraocular movements because the extraocular muscles attached to the eyeball here behind the equator, here the extraocular muscles attach. So the inflammation spreads to the extraocular movements. So when the muscle tries to contract, there is some pain in ocular movements. So that is misdiagnosed because these symptoms are also seen in optic neuritis and other conditions. So it is usually frequently misdiagnosed. So that was about non-infectious. And how to differentiate this non-infectious scleritis from infectious scleritis. The infections like herpes zoster or tuberculosis or syphilis, it is difficult to differentiate, but how we can differentiate is there's purulent exudates are present and fistula are present and the nodules are more painful, conjunctival ulcers and scleral ulcers are seen. So this is how you can see purulent exudates. So if this, usually it is misdiagnosed to be non-infectious and treatment is delayed, but once there is some kind of purulent exudates like this, then we can come to a confirmation that it is some infectious etiology. We can take a culture or swab of this purulent exudate and send it for microbiology culture and we can diagnose. So what are the complications of scleritis? Usually the necrotizing type, that is scleromalacia perforans, which is the inflammation is severe and the inflammation also involves the uvea and the adjacent cornea and also the retina. Here the complications are more because the inflammation spreads to the underlying ocular structures. So it can cause sclerosing keratitis, that is inflammation of the cornea, keratolysis, melting of the cornea, complicated cataract and secondary glaucoma. So this is a case of sclerosing keratitis. You can see this is a type of necrotizing scleritis. The sclera here is necrosed. That inflammation is spreading to the cornea. So here you can see the cornea has got fibrosed. It's like it is some solidified. So the transparent structure is gone. That is called sclerosis of the cornea. So the cornea got sclerosed. And there is also infiltration into the inflammation as the cells have infiltrated into the cornea. This is a sclerosing keratitis, which is one of the complications of necrotizing scleritis. Similarly, the inflammation from the sclera can spread to the underlying uvea and it can cause uveitis, and it can go to retina and it can cause macular edema, and retinal detachment, which we have discussed in posterior scleritis. Similarly, it can spread to lens and the anterior chamber, and it can cause complicated cataract and secondary glaucoma. So how do you manage? So here we have to find out the etiology first. Based on the etiology, we can manage. So whether it is infectious or autoimmune. So how to find out whether it is infectious or autoimmune? All your routine blood investigations, complete blood picture with ESR, erythrocyte sedimentation rate, and serum complement level, rheumatoid factor, antinuclear antibody, early cell phenomena, fluorescent treponemal antibody absorption test, venereal disease research laboratory test for syphilis, serum uric acid for gout, Mantoux for TB, X-ray chest PNS sacroiliac joints, X-ray chest for tuberculosis sarcoid, PNS for vaginal granulomatosis, etc., sacroiliac joint for ankylosing spondylitis, and orbit for any retained foreign body, which could be cause for inflammation. So you have to do all possible investigations, a battery of investigations to rule out all infectious and autoimmune diseases. So how do you treat? For non-infectious condition, you have to give immunosuppressants. So you have to reduce the inflammation. It could be non-steroidal anti-inflammatory drugs, or it could be steroidal. If it is steroidal, you go for topical steroids or systemic steroids. And you can add some systemic non-steroidal anti-inflammatory drugs like aceclofenac, etc. If it is necrotizing scleritis, you can give topical steroids or oral steroids. And if it is not responding to steroids, you can go for immunosuppressive drugs like methotrexate, tacrolimus, pimecrolimus, etc. And if the sclera is going to perforate, you can take a scleral patch graft, a tectonic graft you can put to get the integration of the sclera. And you can avoid, always try to avoid subconjunctival steroids. I told you there is a subconjunctival space and subtenon space. Usually we inject drugs into this space, but when the sclera is already thinned out, better don't inject any drugs because it can aggravate the steroids. They cause further thinning of the sclera and it can cause perforation. That's why avoid subconjunctival steroids in this case. And if the sclera is too much thinned out, you can take a scleral patch graft. That is from cadaver. Eye donation, you might have all listened about eye donation. So in eye donation, from the cadaver, we take the eyeball. So that eyeball, we process that sclera of the cadaver side or the dead body side. And with that, we can process it and we can put it as a scleral patch graft when the sclera is thinned out. And for infectious, based on the type, whether it's syphilis or whatever infection it could be, based on that, you do antimicrobial therapy and surgical debridement. That is remove the membranes, etc. So that was about scleritis. Now this is the most important thing which can be asked as a viva question in your exam. What is episcleritis and what is scleritis differences? All list and differences you should learn. And if you want, I'll share you this PowerPoint later on. So episcleritis, it is a benign thing and a self-limiting, whereas scleritis is potentially vision threatening because we have seen that it causes melting of sclera, retinal detachment, all can be present. And episcleritis resolves fast within 10 days or 3 weeks, but scleritis runs a prolonged course. And it is not, episcleritis is not associated with chronic disorders, but scleritis is usually associated with chronic disorders, especially rheumatoid arthritis in females. Pain is less in episcleritis, more in scleritis. Blood vessels are radially arranged in episcleritis and they're arranged in a branching pattern or arborescent pattern in scleritis. The blood vessels are thin compared to scleritis in case of episcleritis, whereas they're thick and tortuous in scleritis. Similarly, when you put 10% phenylephrine, which is a vasoconstriction agent which causes blood vessels to constrict, the vessels blanch readily with 10% phenylephrine in episcleritis, but they don't branch readily or they blanch after some time in case of scleritis because the blood vessels are located a little deeper in case of scleritis. And level of congestion is superficial on slit lamp examination episcleritis, whereas deeper levels, that is at the innermost layer of episcleral vessels are involved, are more inflamed in case of scleritis. And the nodules are mobile in case of episcleritis and immobile in scleritis. There is no associated uveitis in episcleritis, but associated uveitis is present in scleritis. No vascular patches in episcleritis, but avascular patches are present in scleritis. There is no staphyloma formation. Staphyloma we'll be discussing later on what it is. Staphyloma is nothing but bulging of the sclera or the outer course of the eyeball because of scleral thinning, which is lined by uveal tissue. There is no staphyloma formation in episcleritis, but it can occur in case of scleritis. So these definitions you have to read out again and again. And if you want, I can share this slide PPT later on to you. So coming to blue sclera, the next topic. So we have finished 2 topics, anatomy of the sclera as well as episcleritis and scleritis and what are the differences between them. And now only 2 small topics. What is blue sclera and what is staphyloma? Small topics. So blue sclera is nothing but an asymptomatic condition. There is generalized bluish discoloration of the sclera due to thinning. So usually the concept here is the sclera is white in color and the underlying uveal tissue is brown to blue to black in color. So whenever there is a thinning of the sclera, the underlying uveal tissue shines through it. So when there is any thinning of sclera due to any reason, the underlying uveal tissue shines out through it. So the shining of the uveal tissue gives that discoloration to the sclera, bluish discoloration. So this is how it appears. It is usually a symptomatic condition. The causes being osteogenesis imperfecta, Marfan syndrome, Ehlers-Danlos, pseudoxanthoma elasticum, ophthalmos, hemorrhagia, and healed scleritis. These are the causes. This could be a 2 marks question or a PG bit for you. So these are some cases which I have seen during my PG time. So this is a case of surgically induced necrotizing scleritis. Within 3 months after doing cataract surgery, the patient landed with this kind of a surgically induced necrotizing scleritis, which kept her on some immunosuppressive drugs and local steroids with which it responded. The patient had severe pain. Similarly, this is one case which we have seen in our college here at Gayatri College. So here you can see some amount of bluish discoloration. It is actually not so clear here. This is actually a case of osteogenesis imperfecta, which was referred to us from the pediatric OP. That girl had some bluish discoloration. Along with that, she had other signs of osteogenesis imperfecta, bowel legs, etc. And she suffered from multiple fractures also. And this is another case which we have seen in our Gayatri OP only. This is a blue cornea actually, not a sclera. So congenital cloudy cornea, stumped sclerocornea, tears in Descemet's membrane, ulcer cornea, metabolic disorders, posterior endothelial dystrophy, or all these things come under this one. So this is a case of congenital glaucoma, actually ophthalmos. This patient was from Morocco and Paderu, a tribal patient. The parents neglected him totally. So when he was young, so he developed a ophthalmos or a congenital glaucoma. So it led to a blue color cornea actually. This is not a blue sclera, but it's a blue cornea. And the other eye went into thysis bulbi. So that was about the blue sclera. Now coming to the last one, a small topic, some 5 minutes. So it is a staphyloma. This is again a 4-mark question for you in your exams. So what is a staphyloma? Definition is, so in scleritis what happened? Due to inflammation, there was thinning of the sclera. When the sclera got thinned out, the underlying uveal tissue was shining through that. So whenever there is a thinning of sclera, because of intraocular pressure, the ocular contents tend to bulge out. Just like your hernia in your surgery. Hernia is nothing but protrusion or a distension of your abdominal cavity. Similarly, the protrusion or distension of this eyeball is the localized bulging is known as a staphyloma. So staphyloma is localized bulging of the weak and thinned out sclera plus cornea, which is lined by uveal tissue, which signs to the thinned out fibrous coat. So types of staphyloma based on anatomical location, they are anterior, intercalary, ciliary, equatorial, or posterior. So what are these types? So anterior is, if the cornea is involved, it is called anterior. Intercalary is along the iris root. When it is lined by iris root, it is intercalary. When it is lined by ciliary body, it is called a ciliary staphyloma. When it is present at the vortex vein center, it is called equatorial staphyloma. When it is present anywhere behind the equator, right from behind the equator, anywhere it is present, it is known as posterior staphyloma. So first one is adherent glaucoma. So adherent glaucoma or anterior part. So the anterior one is also known as adherent glaucoma. This is again a 2-mark question which is asked for your seniors in their exam. So it is an ectasia of pseudocornea with iris plastered behind. It might have already been dealt in your cornea chapter. So it is a type of corneal opacity, leukoma. That is the entire corneal thickness is involved. It is called a leukoma. So in leukoma, if that iris is attached to that leukoma, then it is called as an adherent glaucoma. So there are 3 types of corneal opacity, nebula, macula, leukoma. So that when the entire corneal thickness is involved, it is called a leukoma. And when to this cornea or to this leukoma, some amount of iris is plastered, it is called as adherent glaucoma. Usually it is seen after perforated corneal ulcer. When the corneal ulcer gets perforated, the underlying iris gets plastered to that and it forms a pseudocornea. That is known as an adherent glaucoma. So this is how it appears. This was some perforated corneal ulcer. After that, the underlying uveal tissue came and got attached to that and it formed an adherent glaucoma. Similarly, intercalary staphyloma in that limbal area. Limbus is nothing but the junction of sclera and cornea. There the iris root is present. There if it is a localized bulge, it is called intercalary staphyloma. It could be due to any injuries or it could be due to any peripheral corneal ulcers. So secondary angle closure glaucoma may also cause this bulge. And there is defective vision due to corneal astigmatism here. Because it is the limbus is attached to the cornea, there will be astigmatism. Treatment is localized staphylectomy. Locally, we can excise that ectatic tissue and put some patch graft of sclera from a cadaver, or we can put along with oral steroid cover to suppress the inflammation. So this is intercalary. You can see this blue color, this brown color tissue. Almost it should be near the limbus. It is a mixture of both those things. Exact intercalary staphyloma is a very rare occurrence. Usually in case of injury cases, you can see that. And ciliary staphyloma, it is a bulging of the sclera which is lined by the ciliary body, which is usually located 2 to 3 millimeters away from the limbus. It is seen in case of scleritis, absolute glaucoma, or injuries to the eyeball. So here you can see this is a patient who got injured with a stone. After that, here you can see some 2 to 3 millimeter away from the limbus. You can see there is a bulge. That is a ciliary staphyloma. And next, equatorial staphyloma. Equatorial staphyloma, it lines at the equator. Sorry, the picture got overlapped. So here there was an injury. So here you can see the equator. This is where the vortex vein center. So if the eyeball is completely turned up only, you can see this clearly. How there is some bulging of the uveal tissue over there. So posterior staphyloma, it is behind the equator. Anywhere if it is called, there is a bulging, it is called a posterior staphyloma. It is seen in pathological myopia, posterior scleritis, and perforating injuries. So diagnosis, it is usually, we can't go see behind the eyeball on external examination. So usually an indirect ophthalmoscopy. Ophthalmoscopy is examination of the interior of the eyeball, that is the retina and all. So at that time, we can come to diagnose it. So how we come to diagnosis is this. See, suppose this is the posterior pole. Posterior pole is nothing but which consists of the optic disc and the macula. So here, suppose there is a bulging of the sclera, there is thinning out of the sclera, and there is a bulging out of the retina. So the retina protrudes backside. So when the retina protrudes backside, there is a depression present in the retina. So this depression, which can be seen like this. See, the blood vessels are going here and dipping into this. So due to that bulging of the sclera and choroid posteriorly, there is a depression in the retina. So if there is a depression in the retina seen on ophthalmoscopy, then we can diagnose it as a posterior staphyloma. So that was about today's class. Thank you. So finally, the things what we learned today is anatomy of sclera. What is episcleritis? What is scleritis? What are the differences between episcleritis and scleritis? What are the causes of blue sclera? And what are staphylomas? So this is a short topic, but a little confusing topic. Revise it frequently. It will be asked in your Viva questions, and a clinical case can be kept as a short case in your exams. So that's it. Thank you for today. Any questions anybody has? Sorry, I forgot. Any questions you want? Any doubts? Any doubts, any queries regarding today's topic? Okay, the question is, what is the difference between blue sclera and a staphyloma? So blue sclera is usually an asymptomatic condition. So in blue sclera, there is usually no bulging. So the staphyloma definition is, first of all, you have to understand what is a staphyloma. So staphyloma, it is actually a bulging of the sclera. That is, the sclera protrudes outside. The eyeball is not located as a globe. There is some bulging is known as a staphyloma. So in blue sclera, there is no bulging. Just the color of the sclera changes. Only if the color of the sclera changes into blue, it is called a blue sclera, but the eyeball structure is intact. But in case of staphyloma, what happens is, due to thinning of the sclera, in case of blue sclera also there might be thinning, but there is no bulging in case of blue sclera. But in case of a staphyloma, what happens is, due to thinning of the sclera, the eyeball protrudes outside. There is a bulging. That is called a staphyloma. Hope you got my point. Okay. And aren't OVL, the next question is, aren't OVL tract, ciliary body, and choroid parts of sclera? No, no. Actually, OVL tract, ciliary body, and choroids are different parts. They're not parts of sclera. Actually, the eyeball has got 3 layers. First one is the sclera. The second one layer is the choroid. The inner layer is the retina. So the outermost part is called the sclera, which is for the protection. It is mainly meant for protection. The middle part is called as choroid. Choroid is also, the middle part is called uvea. Exactly, if you see, it is called uvea. So uveal tissue is vascular. It supplies the nutrition or blood supply to the entire eyeball. So sclera is for protection, uvea is for blood supply and nourishment, and retina is for the vision part. So when you come to the uvea is a separate topic which Anusha madam will be taking for you later on. So the uvea has got 3 parts. The anterior part of uvea is called iris. Behind that it is called ciliary body, and behind that it is called the choroid. So sclera is a different layer. Sclera is one layer. Beneath sclera, there is a layer called uvea. Beneath the uvea, there is a layer called retina. So the parts of the uvea are iris, ciliary body, and the choroid. That is a separate class, a very big topic which will be dealt by Anusha madam later on. Okay. And next, sir, can trauma be an etiology of scleritis? Yes, it could be, but how you can tell that? Suppose there is a trauma, some bacteria gets lodged in that. Suppose there is a trauma and some staphylococcus or streptococcus comes and gets lodged in the sclera. That can cause to a long-standing or prolonged inflammation. That is one etiology. And the second thing is, sometimes what happens is, along with the bacteria, due to the trauma, the blood supply might be interrupted. So ultimately, the aim of scleritis is it gets necrosed. Why it gets necrosed? Because the blood supply from the episclera, sclera is avascular. Episclera has got the blood supply. So from episclera, through diffusion, the nourishment goes to the sclera. So when there is trauma, there could be damage to the episcleral blood vessels, and that can hamper the blood supply to the sclera, and it can lead to sclera. That is one thing. And then later on, any retained foreign body. Suppose during trauma, some foreign body gets lodged in the sclera and we miss it. Then that can also cause a scleritis. And similarly, bacterial inflammation, they are cause of scleritis. And sometimes due to trauma, also due to some altered immune response, also there could be scleritis. There we can't say that exactly it is due to the trauma or not, but there will be some altered immune response because of some trauma. So that can also be a cause of scleritis. So yes, trauma also can be an etiology of scleritis, but usually secondary causes like retained trauma, retained foreign body, or retained bacteria, or some disruption of blood supply, they could be the more common causes compared to altered immunity there. So, sir, next question is, sir, is suprachoroidal space and subtenon space same or different? No, both are different. Actually, later on, we'll be having a class on orbit. So, in that orbit, we have a topic called as surgical spaces of the orbit. So, basically, if you want to give any drugs, or during in your clinical classes, we'll be telling you mostly that about the surgical spaces of orbit. There are different spaces into it which give anesthesia during cataract surgery. So, cataract surgery, we do under local anesthesia. We give injections into the orbit. So, we give into different spaces of the orbit. So, those spaces could be posterior intraconal space, extraconal space, peripheral space, subperiosteal space. 4 spaces will be there. So like that, there are different spaces are there. So suprachoroid and subtenon space are different. So subtenon space is present between the Tenon's capsule and the sclera. So the layers are, first there is Tenon's capsule. Beneath the Tenon's capsule, there is subtenon space. Beneath the subtenon space, there is the sclera. Beneath the sclera, there is a suprachoroidal space. Beneath the suprachoroidal space, there is the choroid. So that is the order. The outermost layer is the Tenon's capsule. After Tenon, subtenon space. Then there is the sclera. After sclera, suprachoroidal space. After that, choroid. So that is the order. Okay, I hope your doubt is clear. Next is infectious scleritis and bacterial conjunctivitis. Both have purulent discharge. How can we differentiate? Yes, both we have same. Usually that's why infectious scleritis, usually I told you, it is frequently misdiagnosed. Infectious scleritis, they can have purulent discharge. Usually it is misdiagnosed. That's why we give treatment, we give immunosuppressives and it gets flared up. But if you are little clever and if you see clearly, in infectious scleritis, what happens is, the purulent discharge which is there, it remains like a membrane only on the necrosed part. So where the sclera is thin, only on that part will be having the discharge. But the discharge won't come to the eyelids. In case of conjunctivitis, what happens is there will be matting of the eyelashes. Because conjunctiva, when it is inflamed, the discharge comes to the eyelid margin. So the eyelid margin becomes red color. There is lid edema is present and there is matting of eyelashes. This matting of eyelashes will be absent in case of infective scleritis because the discharge is usually confined to the sclera proper and it comes as a layer. And in case of pain will be very severe in case of scleritis compared to conjunctivitis. And the blood vessel arrangement also can be. Both it is arborescent, but it is little difficult to differentiate. Unless we take a culture, we can't. That's why frequently the infectious scleritis is misdiagnosed to be non-infectious scleritis or conjunctivitis, but we have to have a clever look. Unless we have a cautious look, we can't differentiate. One thing is matting of the eyelashes, that point we can take. In case of conjunctivitis, matting of eyelashes and pain and all, and lymph node involvement if it is there, and conjunctivitis, if it to one eye it comes, it almost spreads to the other eye. And in case of fever and all, based on the symptoms, we can tell that. And conjunctiva is not a part of sclera. Conjunctiva is completely a different part. So once in your conjunctiva chapter, one diagram will be given in your Kurana. Once see that. So the conjunctiva is present only on the anterior 1/6 of the eyeball. Only on the anterior part of the eyeball, there is a covering called as conjunctiva, which is thin and transparent. It is not a part of sclera. Sclera is different. Conjunctiva is different. So I told you that sclera is covered by Tenon's capsule. Anteriorly, the Tenon's capsule is again covered by another layer which is called conjunctiva, and the conjunctiva has already been dealt by you by Sahiti madam in your previous classes. So the sclera is covered by a Tenon's capsule all around. Anteriorly, along with the Tenon's capsule, there is also a covering called the conjunctiva, which is also present over the sclera. So conjunctiva is different from sclera, and the uveal tract is also different from sclera. Initially, it is confusing. Once you come to the end of the year, when you have covered all the topics, all the classes have been over, then you'll get a clear idea about the picture. And when you come to your clinical postings later, then again we'll be able to explain you clearly what are the different parts with the help of diagrams. Okay. Any more queries, or is it okay? So all your doubts, all of you clarified. Since it's conjunctiva, but actually they are not part of sclera. It is conjunctiva is a covering of the sclera. Conjunctiva is a covering which is present over the sclera. Conjunctiva is different, sclera is different. Over the anterior part of the sclera, there is a covering of conjunctiva, but conjunctiva is not present all over, but they get blended. At the limbus, what happens is this conjunctiva, sclera, Tenon's capsule, all is blended together. All is blended together at the limbus. That's why during surgery, with forceps to fix the globe, we hold at the limbus. At the limbus, what happens is this conjunctiva, sclera, and cornea, all is together joined and form one layer. So there the thickness is very tight, and so we can get a good hold during surgeries also while performing cataract or pterygium excision. So that's it. But conjunctiva is completely different, sclera is completely different. Okay. And anything still you have any doubt, when you come to clinical postings, once you ask me that. Okay. So hope all of you are clear. Okay. That's it, no? Okay. Doubts. Close this.